Good morning, everybody. And we convene this hearing in the Subcommittee on Oversight and Investigation on, quote, budget and spending concerns at Health and Human Services, end quote. This is our fourth in our series of oversight hearings on the federal budget. This hearing aims to determine the results of the Department of Health and Human Services their efforts to identify wasteful, duplicative, or excessive spending and to assist in finding more spending cuts and savings, pursuant now to the President's ordered line-by-line review. HHS is the largest agency by budget under the committee's jurisdiction and is second only to the Department of Defense. The President's fiscal year 2013 budget requested $941 billion in outlays and $77 billion in discretionary budget authority for Health and Human Services, an increase of nearly 8% over last year's outlays, and a slight increase over last year's discretionary budget. This increase is in addition to the $140 billion in Recovery Act funds provided to Health and Human Service programs. HHS, as recently as 2009 fiscal year, was an agency of nearly 80,000 federal employees. According to FY 2010 Office of Personnel Management data, these include 91 of the federal government's top 100 highest paid civil servants and 651 of the federal government's top 1,000 highest paid civil servants, and Health and Human Service continues to grow. Between the year FY 2007 and 2013, the number of full-time equivalents rose from 64,000 to 76,000, an increase of about 20%. At an agency as large as HHS, opportunities are ripe for wasteful and duplicative spending. It is clear that HHS has a long way to go to streamline its many multi-billion-dollar program and restore trust in its management of our tax dollars. For example, HHS, just like DOE, failed to heed the President's April 2009 order to Cabinet Secretaries to identify a combined $100 million in budget cuts by July 2009, and there is clearly waste. The Center for Disease Control's Communities Putting Prevention to Work program, for which the Recovery Act made hundreds of millions of dollars available to them, have paid for signage to promote recreational destinations, intergenerational urban gardening, and community bike sharing programs around this country. CDC's website even boasts that money under this program was provided to Hawaii, to develop remote school drop-off sites to encourage students and staff to walk further distances to school entrances, end quote. Perhaps HHS is telling Congress that we should eliminate mass transit as part of our war against obesity. Incredibly, this same program also funded free pet spraying and neutering. While a laudable goal, the Department of Health and Human Services should focus its limited resources on human health. Now, my colleagues, just last month, GAO released a report on the Medicare Advantage Quality Bonus Payment Demonstration Program, which it estimated will cost about $8.4 billion over 10 years. Secretary Sebelius says that she intends to go forward with this project despite the fact that GAO concludes that it is unprecedented in size and scope and its design, quote, precludes a credible evaluation of its effectiveness, end quote. Obamacare stipulates cuts in Medicare Advantage funding. Therefore, the Wall Street Journal has suggested that the purpose of the demonstration project is to give a program that is popular with seniors a temporary reprieve just past Election Day. And I think the Wall Street Journal is right. When we are borrowing 40 cents of every dollar we spend, we need to ensure that the American taxpayers are getting the proper value for their tax dollars. In order to learn more about Health and Human Services efforts, we will take testimony today from the Deputy Assistant Secretary of Budget at HHS, Norris Cochran, and Directors of Healthcare at GAO, Carolyn Yocom, and James Cosgrove, who will be providing joint testimony. And I welcome these witnesses this morning. I would point out that HHS Office of the Inspector General declined the subcommittee's invitation to testify at this hearing, noting that due to statutory mandates and funding streams, it spends 80% of its limited resources on fighting fraud, waste, and abuse in the Medicare and Medicaid program. The IG also confirmed that it has not done any significant recent work looking at duplicative programs within HHS, nor does it have plans to conduct such a review in the near future. For this reason, only GAO will be present at the hearing to provide an independent outside assessment of Health and Human Services effort to identify wasteful, duplicative, and excessive spending within the agency. In the absence of the IG, this subcommittee's role in providing much-needed oversight of HHS spending and operation becomes all that more crucial and important. This subcommittee and the committee as a whole must remain deeply and regularly engaged with the agencies within its jurisdiction, including HHS, as they define their priorities, identify their needs, and set their goals for the years ahead. With that, I recognize Ms. Jan Schakowsky, the ranking member who is substituting, as I understand, for Mr. Gett.
Thank you, Mr. Chairman. It's my honor to be sitting in for Congresswoman Diana DeGette this morning as ranking member. Led by my Republican colleagues, we're here to talk about spending priorities in the Health and Human Services budget. Given the substantial short and long-term deficit challenges we face, I understand the need to root out wasteful spending and ensure that every agency is being fiscally responsible. Because our test is to address those challenges while simultaneously constructing a strong foundation for a healthy and bright economic future for our country, I must point out what I see as the misplaced focus of my Republican colleagues. In March, the Republicans passed an irresponsible budget that will only make things worse for the middle class and those who aspire to it. The Republican budget makes it clear that their party puts the very richest Americans as the top priority and makes everyone else bear the burden. The Republican budget would do nothing to address income inequality. Instead, it would make it worse by increasing defense spending while slashing investments important to job creation, seniors, children, and the middle class. The Republican budget mandates additional cuts to discretionary programs like Medicaid, food stamps, the Social Services Block Grant, and the Prevention and Public Health Fund to insulate the Department of Defense from spending cuts triggered by the failure of the Joint Select Committee on Deficit Reduction. Our committee was directed to find at least $97 billion in cuts, nearly half of which came from public health programs. The committee has lost valuable time that we could have spent discussing ways to get needed health care to Americans who have lost their health insurance along with their jobs or who cannot afford costly insurance premiums. Instead, my Republican colleagues have repeatedly attacked Obamacare, and once again they seek to repeal the law in their budget. We should be working to lower health care costs by improving efficiency and providing access to prevention. Instead, my Republican colleagues have railed against the Prevention and Public Health Fund and repeatedly used its funding to force choices we shouldn't and don't have to make, like the choice between the elimination of funding for the Preventive and Public Health Fund or relief for students who are saddled with student loan debt. If we want to build a healthier, economically strong America, we must maintain our investment in prevention. Understand what the fund is about. It's about preventing diabetes, heart disease, cancer, and it's about getting money to state and local governments and organizations so they in turn can put prevention programs in place that are designed to meet the needs of their communities. This is about keeping America healthy. My colleagues on the other side of the aisle lose sight of this goal when they try to rile people up by labeling the Prevention and Public Health Fund as a slush fund. It isn't. Under the President's 2013 budget, the fund would support breast and cervical cancer screenings. Americans know that mammograms and pap smears are not slush. They are basic, routine, and often life-saving services for women. Cutting funding for prevention programs like breast and cervical cancer screening now will only lead to increased costs down the road. I have to say I'm really disappointed that some of my colleagues continue to say that the CDC funds or the prevention funds are used to spay and neuter dogs. They are not. HHS has confirmed it. Yet the same talking point that was used in committee making this claim was used on the floor during the student loan debate. The late Senator Moynihan said, "Sir, you are entitled to your opinion, not your own facts." And Mr. Chairman, the priorities in the Republican budget are deeply flawed. They do not reflect the priorities of everyday Americans. While I believe the focus of this hearing is misplaced, I still hope that we can have a serious discussion about reducing our deficit without hurting the programs that benefit low-income families, children, seniors, and individuals with disabilities. I yield back the balance of my time.
I thank the gentlelady. I have here the recovery.gov website that confirms that the spay and neuter and wellness clinics for cats and dogs have been well received in 2 zip codes with higher rates of animal nuisance report. With that, I recognize the, and also it was included Department of Health and Human Services, part of the Metro Public Health Department's Community Putting Prevention to Work campaign. Here's the thing. I'll let you look at that, dear. With that, I look at the Chairman Emeritus of the full committee, the gentleman from Texas, Mr. Barton.
Thank you. Thank you, Mr. Chairman, for holding this hearing along with the ranking member, Ms. DeGette. The Department of Health and Human Services is an agency that spends over $1 trillion. $1 trillion is more than the entire federal budget spent the first year I was in Congress in 1985. $1 trillion is more than the total GDP of almost every nation in the world. $1 trillion is so much money that we can't even get our hands on it. It's obvious that HHS can't get their hands on managing it either. The Inspector General at HHS declined to testify, admitting to subcommittee staff that the department was so big and their resources so constrained that they have to focus everything they're doing on 2 programs, obviously the 2 biggest, Medicare and Medicaid. Obviously, HHS has a huge mission to protect the health of the American people. This is a daunting challenge. Having said that, it doesn't mean that we just throw up our hands and throw money at the problem. There are over 80,000 employees at HHS. There are about 40,000 cardiologists and neurologists in this country, so we have 2 HHS bureaucrats for every cardiologist and neurologist that are actually trying to provide health services to the American public. President Obama has talked a good game about trying to manage the agencies better, but HHS is one of the agencies that when the President specifically directed that certain steps be taken to eliminate waste, fraud, and abuse and to cut overhead, HHS didn't provide a program. Didn't even attempt it. So, Mr. Chairman, here we have an agency that has a huge mission, admittedly, but their answer to every problem is to create more bureaucracy that is more unmanageable and more uncontrollable. Hopefully this subcommittee on a bipartisan basis will first determine what the facts are, and then perhaps we can get with the health subcommittee and start some sort of an reauthorization to put into statute some of the things that need to be done. With that, I thank the chairman for his discussion.
Thank the gentleman. And the gentleman from Texas, Dr. Burgess, is recognized for 2 minutes.
Thank the chairman for the recognition. We are today focusing on the discretionary budget authorities within Health and Human Services, and recognize it represents almost a quarter of all federal outlays. President Obama has proposed $76 billion in discretionary spending for fiscal year 2013 in Health and Human Services. Now, both as an agency for HHS, both as an agency working on public health and administering public health programs, it has to be the center of the universe in government integrity efforts. If we cannot get it right at HHS, where can we get it right? And if we get it right at HHS, everything else looks easy by comparison. Yet on November 14 of 2011, the Inspector General of Health and Human Services, Inspector General Levinson, notified Secretary Sebelius that an independent audit of Health and Human Services fiscal year 2011 financial statements found that, quote, weaknesses continue to exist in financial management systems, close quote. The Inspector General also confirmed that it has not done any significant recent work in looking at duplicative programs within Health and Human Services. So I guess we have to ask ourselves, how much fraud is enough for the government to take notice? I'll tell you the answer. The answer is zero. And it must be zero. And that must be the focus at Health and Human Services. But really, the lack of internal oversight The lack of prosecutors with a background in healthcare law really compromises our abilities to actually get anything done. So, are we comfortable with the current situation? I can't believe that we would be. And if we're not, when are we going to correct it? That applies to the committee, both sides of the dais, and it applies to the agency, everyone from the secretary on down. Healthcare expenditures are going to go nowhere but up, and Health and Human Services work in public health is going to continue to rise. Developing new and innovative approaches must make sure that every dollar is spent where it belongs, and that's delivering services to the people. I yield back.
Gentleman's time has expired, and our side is complete. We recognize the rank. Oh, Ms. Blackburn, I'm sorry. Yes, the gentlelady from Tennessee is recognized for 1 minute. Sorry.
Thank you, Mr. Chairman. I thank you for the hearing. Welcome to our witnesses. We are glad that you're here. As you've heard, this is a necessary hearing. It's our fourth in a series to look at waste, fraud, and abuse. And the reason we're doing this is because our constituents come to us and they let us know they are taxed too much, they are tired of it, and they are frustrated with seeing the waste in our federal bureaucracies. HHS employs over 80,000 federal workers, and you do have a large portion of our budget that you're expending every day. Mr. Cochran, specifically for you, I want to hear about the steps that HHS has taken to comply with the President's call for agencies to identify $100 million worth of administrative savings nearly 2 years ago. See where you are in that process. Additionally, let's quantify generated savings from the President's Executive Order 13589 from November 9th, 2011, and I want to know what is actual savings and then where you have double counted or used funds to justify your cost increases or activities. And finally, after our experience with the Department of Energy and Solyndra, I have very real concerns about similar financial mismanagement at HHS as brought to our attention by Ernst & Young, and we'll explore that a bit today, and I yield back.
Thank you, gentlelady. And now recognize the ranking member of the minority, Mr. Waxman from California.
Mr. Chairman, wasteful federal spending should be eliminated. Fraud and abuse should be wiped out. I've long supported bipartisan efforts to cut spending and reduce waste and fraud. But we must recognize that HHS and the agencies contained in the department have a vital, life-saving mission, providing health care to millions of Americans, investing in disease prevention and scientific research, keeping the food and drug supply safe. We must be smart about how we achieve savings, or we put these important programs at risk. Mr. Chairman, if you want to learn how to cut the budget in a sensible way, I'd suggest you take a look at the work we did in the Affordable Care Act. A Democratic Congress, working with President Obama, passed into law provisions that cut waste and abuse from Medicare and Medicaid. We gave HHS important new authority and power to identify and prevent Medicare and Medicaid fraud. The net result is hundreds of billions of dollars in savings without the need to cut Medicare benefits or erode the core promises of the program. Unfortunately, the cuts in the Republican budget passed by the House doesn't meet this standard. They take direct aim at our nation's commitment to provide health care to seniors and our most vulnerable citizens. The Republican budget would repeal the Affordable Care Act and the basic Medicare guarantee by turning the program into a voucher system, directly cut seniors' benefits by increasing the Medicare eligibility age, and slash funding for Medicaid, breaking the social safety net. The Republican budget would also deny coverage to 33 million Americans and allow the worst abuses of the insurance industry, like denying coverage to those with pre-existing conditions, to continue. And it would cut off benefits, like coverage of young adult children and closing the Part D drug donut hole that millions of Americans are enjoying today. The Republican budget's Medicare cuts would eliminate the program's basic guarantees. They would increase costs for seniors, according to CBO, by up to $2,200 per beneficiary starting in 2030. This is not holding down costs. This is simply shifting costs. And the Republican budget would increase the Medicare eligibility age from 65 to 67, meaning millions of older Americans would be stuck waiting for Medicare with no employer coverage or inadequate coverage. The Republican budget also cuts Medicaid by a stunning amount, $1.7 trillion over the next decade, turning the program into a block grant and threatening access to health care for millions of low-income children, families, pregnant women, and seniors in nursing homes. And Mr. Chairman, the Republican budget does more than devastate Medicare and Medicaid. FDA, NIH, CDC, Head Start programs are all part of HHS. The Republican budget will hurt all of them. The Republican budget cuts non-security discretionary spending for all government agencies, including HHS, below levels agreed to under the Budget Control Act by 5% in 2013, by 19% in 2014, and beyond. The Republican budget lacks specific details, but the implications are clear. Cuts in the FDA budget for food safety and inspection, cuts in the NIH budget for basic scientific research, reduced capacity for CDC to respond to emerging diseases, fewer kids who are eligible for Head Start, less money to fight Medicare and Medicaid fraud. These cuts in basic health programs would be a huge mistake. They would be penny-wise and pound-foolish, costing our nations more money and more in terms of human suffering than they could possibly save. Mr. Chairman, I hope we can find a way to work together to find bipartisan solutions to cutting waste, fraud, and abuse at HHS and at other agencies in the federal government. But the Republican budget proposal is not the answer. It cuts Medicare and Medicaid, eliminates health care coverage for 30 million Americans under the Affordable Care Act, and it includes devastating cuts to basic programs at FDA, NIH, CDC, and throughout HHS. I hope the Republicans will rethink that approach, and I yield back my time.
Thank the gentleman. Just remind him we're looking at budget and spending.
I'm going to reclaim my time to say that I don't think it's appropriate for the chairman to comment on each Democratic statement.
Well,
we have 5 minutes each side.
I know.
If somebody on your side wants to yield your time.
I appreciate what you're
But I do want to point out that I don't understand this business of neutering dogs. Is this a
well, we've given you
an anti-abortion issue? Is
No,
this
this
a
is-
family planning issue? Is this something where we have huge, is this your waste, fraud, and abuse?
It certainly
I like to yield to the chairman unlimited time, but
Sure.
I don't have the power to do that.
unlimited time. Well,
I'm sure
I've
he'll
given
take it if he
you,
wants.
I've given you the brochure just to corroborate my opening statement and also to point out we're talking about budget and spending concerns at HHS. With that, let me introduce our witnesses. Mr. Norris Cochran, Deputy Assistant Secretary, Office of Budget, United States Department of Health and Human Services. Ms. Carolyn L. Yocum, Director, Healthcare, U.S. Government Accountability Office. And Mr. James C. Cosgrove, Director, Healthcare, U.S. Government Accountability Office. And I understand the two of you, there'll be a joint statement from the two of you. Is that correct? As you know, the testimony that you're about to give is subject to Title 18, Section 1001 of the United States Code. When holding an investigative hearing, such as this committee is doing, the committee has a practice of taking testimony under oath. Do you have any objection to taking testimony under oath? The chair then advises you that under the rules of the House and the rules of the committee, you are entitled to be advised by counsel. Do any of you wish to be advised by counsel? In that case, you please rise and raise your right hand. I'll swear you in. Do you swear the testimony that you're about to give is the whole truth and nothing but the truth, so help you God? Okay. We now welcome your 5-minute summary. We'll start with you, Mr. Cochran.
Thank you. Chairman Stearns, Representative Schakowsky, members of the subcommittee. Thank you for the opportunity to speak about the Department of Health and Human Services stewardship of the resources provided by Congress. In my role as the budget director at HHS, I oversee the formulation of our annual budget. I and my colleagues in the department are committed to efficiently achieving the outcomes intended by Congress. I will keep my initial remarks brief and respectfully request that my written testimony be incorporated into the record.
So ordered.
Thank you. I will briefly summarize key aspects of the President's FY 2013 budget request for HHS, including the use of unobligated balances, and highlight efforts to improve program performance and integrity and to achieve savings. The FY 2013 budget for HHS totals $932 billion in budget authority and $941 billion in outlays. It's comprised of many types of funding, including Medicare, Medicaid, and other entitlements and other mandatory spending, discretionary budget authority, user fees, and funding made available through transfers of other sources such as the Prevention and Public Health Fund and the Public Health Service Evaluation Set-Aside. As HHS develops the annual budget request, we conduct a thorough review of our ongoing activities and eliminate or reduce funding for outdated, duplicative, and low-performing programs. The HHS discretionary budget request includes more than $2 billion in reductions and eliminations across HHS's many components. These reductions and terminations are informed by analysis of impact and performance data and the setting of priorities in a tight budget environment. These reductions are enabling HHS to propose a discretionary budget that is cut overall by $218 million while still making priority investments in key areas, including biodefense to protect the safety of our nation through the development of medical countermeasures, the Indian Health Service to address extreme health disparities experienced in Indian country, and the Centers for Medicare and Medicaid Services to keep up with beneficiary growth and implement the Affordable Care Act. In addition, HHS proposes net mandatory savings of $366 billion over 10 years. These savings include $303 billion in Medicare, $56 billion in Medicaid, program integrity savings, as well as mandatory investments to strengthen child support enforcement, child care and foster care, and to continue TANF-related activities. In developing our annual budget, HHS with OMB also assesses whether the presence of unobligated balances enables the department to request less funding from Congress than would otherwise be needed. For example, the budget request this year for bioterrorism and emergency preparedness assumes the use of more than $400 million in unobligated balances to achieve our preparedness goals. As HHS components execute the budget, we continually work to eliminate unnecessary costs. For instance, HHS is currently in the process of reducing our spending in targeted categories, such as travel and supplies, by more than $800 million. HHS program and policy leaders also monitor the outcomes of the programs we administer and make needed adjustments to improve program performance. This is exemplified by regular data-driven meetings chaired by our Deputy Secretary, during which senior officials review progress and key next steps for achieving measurable priority goals. In the areas of program integrity and budget execution, HHS benefits from the expertise of the HHS Office of Inspector General and the Government Accountability Office. For instance, before we spent funding from the Recovery Act, we worked with our OIG colleagues to better prevent waste, fraud, and abuse with those investments. With respect to program integrity, we are particularly proud of a joint effort with CMS, the Office of Inspector General, and the Department of Justice, through which multi-agency teams of federal, state, and local investigators combat Medicare fraud. Just last week, charges were made against 107 individuals for their alleged participation in Medicare fraud schemes involving approximately $452 million in false billing, which represents the largest single takedown in the history of this effort. In conclusion, Mr. Chairman, thank you again for inviting me to testify about HHS stewardship of taxpayer resources. I look forward to answering your questions.
Thank you, gentlemen. Mr. Cosgrove, your opening statement, please.
Chairman Stearns, Ms. Schakowsky, members of the subcommittee, I'm pleased to be here with my colleague, Carolyn Yoakum, as you discuss budget considerations at HHS, which is responsible for both discretionary spending and mandatory spending. These funds support a variety of important activities. However, the overwhelming share goes to Medicare and Medicaid, and for that reason, our remarks today focus on HHS's responsibilities for those two programs, which are administered by the Department's Centers for Medicare and Medicaid Services. Over the past several years, GAO has recommended that HHS and CMS take a variety of actions to enhance agency oversight of Medicare and Medicaid and foster more prudent spending. We are pleased that many of our recommendations have been implemented, saving money for taxpayers and beneficiaries. For example, CMS saved at least $3.4 billion over 5 years from implementing multiple recommendations on the oversight of Medicaid supplemental payments. However, some of our recommendations remain unaddressed, and so today we want to focus on those key recommendations made within the last 6 years where HHS has not taken action or only partially addressed the recommendation. Some of our still open recommendations would help reduce improper payments and enhance payment safeguards in traditional fee-for-service Medicare. For example, we recommended that CMS require its contractors to identify potentially improper claims when billing reaches atypical levels. CMS agreed, but has not implemented our recommendation. We recently noted that CMS could better screen providers to avoid enrolling those who are intent on committing fraud. To enhance payment safeguards, in a 2008 report, we recommended that CMS adopt front-end approaches, such as considering requiring prior authorization for certain diagnostic imaging services. Although not implemented, the President's 2013 budget does call for such an approach. We also believe that HHS needs to address certain issues related to the Medicare Advantage program. Approximately 1 in 4 beneficiaries are enrolled in private health plans that participate in Medicare Advantage. These plans are popular because, relative to traditional Medicare, they typically cover more services and cost beneficiaries less. However, Medicare's payments to these plans, specifically the adjustments for beneficiaries' health status, could be improved, and $1 billion or more could be saved annually. We recommended specific steps that CMS could take to better ensure the accuracy of its required payment adjustment. CMS commented that our findings were informative, but did not indicate that it would implement our recommendation. We also recommended that HHS cancel its quality bonus payment demonstration for MA plans. This demonstration, estimated to cost more than $8.3 billion, is poorly designed and unlikely to yield meaningful results. Although intended to encourage high-quality health care, most of the money will go towards plans of average quality. Moreover, because of design shortcomings, it will be nearly impossible to evaluate whether the $8.3 billion influenced the quality of care provided. We therefore recommended that HHS cancel the demonstration and implement instead the quality bonus payments provided for by PPACA, which pays bonuses only to plans that achieve above average quality levels. Our substantial work on the Medicaid program has also resulted in numerous recommendations to improve program management, several of which remain open. For example, gaps remain in the oversight of state supplemental payments to hospitals and other providers for uncompensated care. We recommended that CMS make such payment arrangements transparent and ensure that the agency has reviewed and approved these arrangements. CMS has acted on some of these recommendations, but we believe additional action is warranted. Several times we've reported that HHS had approved state Medicaid demonstrations that could increase federal costs, despite a policy against such increases. HHS has since reported taking certain steps, such as monitoring the budget neutrality of ongoing demonstrations. However, no changes are planned in the methods used to determine budget neutrality and ensure the federal government's financial liability is not increased. CMS has been inconsistent in reviewing states' rate setting for compliance with Medicaid managed care actuarial soundness requirements. In 2010, we found that one state received billions of federal dollars that had not been certified by an actuary, and another state's rates hadn't been fully reviewed since the requirements went into effect. We recommended that CMS improve its oversight of state rate setting, and while HHS agreed with their recommendations and has taken steps to improve its oversight, it has not yet completed actions that would ensure the quality of the data or develop the guidance for reviewing the rates. In conclusion, given the size and scope of the programs for which it's responsible, HHS must be vigilant in seeking ways to reduce spending, prevent improper payments, and improve the efficiency of operations. We look forward to working with this committee to help the department further advance its performance and accountability. We're happy to answer any questions you might have.
Thank you. And with that, as I understand, Ms. Yoakum, you're here to assist if we have any questions. You're sort of a detailed expert.
That's correct.
All right, dear. Let me start by Mr. Cochran, I think you just heard Mr. Cosgrove indicate in his opening statement many things that he indicated he has recommended you have not done. Isn't it true that the President is committed to conducting an exhaustive line-by-line item in the spending budget to reduce unnecessary waste, fraud, and abuse? Isn't that true? Yes or no?
Yes, we go through an exhaustive review each year.
And the idea was to increase, efficiency and to overall provide ways to do better with less. I think that was the idea, and in fact, that's what the GAO had indicated to you, that we want to do more with less. I think we have a hard time realizing the statistics I gave you this morning in my opening statement about the huge number of employees increase and the amount of money you've got. It doesn't appear that you are actually doing more with less. And when I hear Mr. Cosgrove talk, he noted that has implemented some of the recommendations, but not all of the GAO recommendations to conserve HHS funds and strengthen the oversight of this program. So I guess the question is, why haven't you implemented the many other detailed recommendations that he mentioned, including one that caught my eye was dealing with bonuses that he brought to bear on your watch? So I guess that's the main question is, considering what we see here, for example, canceling the MA quality bonus payment demonstration program. I guess, why haven't you implemented all the other things that he suggested?
Well, CMS has leadership for managing Medicare and Medicaid, and as we heard, has made a number of the changes. We've also incorporated a number of recommendations and findings into our annual budget requests, such as in the area of medical devices. We're finding efficiencies through identifying discretionary programs.
No, the question is, why haven't you implemented the other recommendations? You've implemented some, is what Mr. Cosgrove said, but the ones he detailed and outlined, why haven't you done those?
There are...
You don't have the money?
Well, there are different reasons. Again, this is managed principally by CMS at the operating division level. In some cases, it could be an issue of whether or not they have existing authorities. In other cases, CMS continues to work with and talk to GAO.
Okay, so you're working on them. Is that what you're saying?
In a number of areas.
Now, canceling the MA quality bonus payment demonstration, there's an estimate here, it could save $8 billion over 10 years. Are you familiar with that recommendation?
I am familiar with the...
Is there a reason why you didn't implement that recommendation from the GAO?
The Secretary has, as she's testified to the House, has indicated that HHS has made a policy decision to continue that demonstration.
Even though the GAO said it should be canceled, you have agreed to override their recommendation. Is that true?
The position of the department, as articulated by the Secretary, is to continue.
So you're going to override their recommendation. I understand. I just want to understand that if they make a recommendation, you don't agree with it, you're just not going to implement it. I have a slide here that, if possible, I'd like to bring up. The number of full-time equivalents, or FTEs, at HHS have been rising over the past several years. Is that true, yes or no? Looking at this chart will give you, it's a little hard to see. I mean, you just confirmed to us that the budget continues to grow, as does the number of full-time equivalent employees. In fact, the President's request of Congress for HHS funding from year to year continues to rise. Isn't that true?
The areas where we've had FTE growth are principally in the Food and Drug Administration, which is funded both by budget authority provided by the Congress and by user fees from industry, as well as the Indian Health Service, which provides direct medical care to Indian country in those populations.
Mr. Cochran, the HHS was apparently absent from the list of the 15 agencies that were heeding the President's April 2009 order to Cabinet Secretaries to identify a combined $100 million in budget cuts by July 2009. Wasn't that true that you were absent from that?
HHS identified savings in two areas. That process is managed by OMB. You're correct that it was not carried in that memo. The two areas that HHS identified subsequent to the delivery of the memo are in data centers, where we've consolidated data centers in CDC and FDA starting in FY 2009, and the migration from paper to electronic filing, principally in FDA, but as well as CDC and ACF.
Well, I think you can realize from this standpoint, it just seems odd that given the President has instructions in April 2009, in his first major actions, attempt to demonstrate a serious effort to cut budgets and to streamline federal spending, and at the same time, HHS was apparently absent from the list of the 15 agencies that were heeding the President's April 2009 order to Cabinet Secretary. So we just find that a little puzzling. And my time has expired. I represent the ranking member, Ms. Schakowsky.
Thank you, Mr. Chairman. I'd like to ask the witnesses some questions about Medicare's fraud prevention efforts. Reducing fraud has been an Obama administration priority, and we're seeing significant taxpayer savings as a result of these efforts. The administration's anti-fraud efforts recovered a record $4.1 billion taxpayer dollars last year. It's the second year in a row for a new record. And the administration has recovered a total of $10.7 billion over the past 3 years. Prosecutions are way up from 797 in fiscal year 2008 to 1,430 in fiscal year 2011, a more than 75% increase. So the Affordable Care Act gives HHS a broad range of new tools to reduce waste, fraud, and abuse. A national screening program, and I heard Mr. Cosgrove talk about pre-screening for providers, enhanced screening for providers in high-risk areas like durable medical equipment, home health care, required disclosure of prior association with delinquent providers and suppliers, on-site visits as part of the enrollment process, new CMS powers to enact a moratorium on enrolling new providers and new funding to fight fraud. So, Mr. Cochran, can you offer some perspective on these new tools and how will they help CMS cut fraud?
Yes, as you note, this has been a major area of focus for the administration. A number of recoveries has increased dramatically, as you note, in the last 3 years alone. Totaling $10.7 billion. Some of the authorities that CMS is now using that come specifically from the Affordable Care Act include efforts to create risk-based screening process for new and enrolling providers. Also, importantly, CMS now has the express authority to suspend payments to a provider or supplier pending the investigation wherever there is a credible allegation of fraud. In addition, the Act, for example, requires face-to-face encounters between patients and practitioners prior to a physician certifying eligibility for Medicare's home health. The Act also provides resources that are available to CMS and our Office of Inspector General, again, where we partner with the Department of Justice in our healthcare fraud and abuse control areas.
And Mr. Cosgrove, would you agree that these new authorities under the Affordable Care Act will help HHS fight fraud?
With your permission, I'd like to see if Carolyn Yoakum could address the question. Carolyn is an expert both on the Medicaid program, on the overall program integrity efforts.
Yes. Good morning. We would agree that there is more work for CMS to be done, and some elements of PPACA do help provide the aspects of improvement. Our three areas where we would suggest that CMS continue to do work have to do with the provider enrollment, making sure that those enrollments are strengthened and that there is core elements for provider compliance in place. A second area would be looking at post-payment claims review and also prepayment claims review, which prevents the money from even going out the door until it's certain that it should. We have ongoing work in those areas. And then lastly, to look at weaknesses within identifying known vulnerable areas. And again, we have ongoing work in this area that we expect to be reporting on. Okay.
Thank you. The CBO has estimated that these changes will save more than $7 billion over the next 10 years. So clearly, and I think that CMS agrees, more needs to be done. But would you say that what's happening right now is a step in the right direction?
Yes, it is a step in the right direction. We have not done work looking at the savings. That's CBO's jurisdiction.
Okay. And I'm wondering, Mr. Cochran, in your testimony, you noted something that many of us saw on the news just last week. 107 people were charged in a $450 million Medicare fraud scheme, the largest Medicare fraud ever. What can you tell us about the administration efforts that resulted in this bust?
Well, one key aspect in this effort is that it's a collaboration between HHS and the two components there, principally being the Centers for Medicare and Medicaid Services and our Office of Inspector General and the Department of Justice. Another key aspect is that it involves both taking intelligence from headquarters, but also importantly, focusing with agents and experts on the ground in 9 key areas, strike forces they're called, in higher risk areas, and that's enabled HHS and DOJ to really step up enforcement by having more direct involvement where we face the greatest amount of fraud.
Mr. Chairman, I know my time is up, but I went out on a drive around with the strike force, and I would recommend that it's very worthwhile for members in those areas to do that. Thank you.
Gentlelady's time has expired. Ms. Cherry from Nebraska is recognized for 5 minutes.
Thank you, Mr. Chairman. And continuing with you, Mr. Cochran, just so I can better understand our efforts on waste, fraud, and abuse, there's nothing that frustrates our constituents more than abuse of something so sacrosanct as our Medicare and Medicaid programs. They, especially as seniors, really feel cheated when somebody's stealing from the program. They feel like they have been stolen from. Of course, there's different levels. There's outright fraud. There's improper payments, which may not be fraud, but still payments that shouldn't have been made. So I want to break this up into a couple different areas. First of all, on page 2 of your statement, Mr. Cochran, when I was reading it, you mentioned that you seek opportunities, or the agency seeks opportunities to make investments that will yield greater returns in the future, such as the Healthcare Fraud and Abuse Control Program that has returned over $20 billion to the Medicare Trust Fund since 1997. And then has a return on investment of 7.2 to 1, but yet we're hearing today from statements that there's been hundreds of billions saved in the last 2 years and 42 billion saved over the last 2 years. So that begs the question of whether there are more healthcare fraud and abuse control programs that weren't referenced in your statement.
The initial description of recoveries to the trust funds, including the $10 billion over the last 3 years, is in reference to the work that we're doing with DOJ and healthcare fraud and abuse. The larger numbers, if I understand your question, relate to not necessarily fraud and abuse. Some of the savings in both the 2013 budget as well as the Affordable Care Act relate to fraud and abuse. Others are reductions in payments, again, often informed by GAO's analysis, as well as efforts to improve quality and reduce costs.
It's reduced payments. Is that an issue of correcting improper payments? Because reduction just means you're paying somebody less.
Well, in the area of improper payments, there can be...
well, no, I'm just asking for further clarification when you said that those further savings came from reductions of payments. I want to know if those were improper payments that were pulled back, or just simply a reduction, like a doctor was paid $48 instead of $50?
I see. Yes, and with my reference to reduced payments relates to areas where CMS, GAO, in some cases OIG, and we also work closely with Office of Management and Budget in this area, where we have found that reimbursements are sort of out of balance or exceed what should, arguably be provided for the level of service, and so through legislative changes and budget proposals, those reimbursements are something.
Well, let's follow up on that, Mr. Cosgrove. That GAO has designated Medicare and Medicaid as a high-risk programs due to their susceptibility for improper payments, estimated to be about $65 billion in fiscal year 2011. Mr. Cosgrove or Ms. Yoakum, does HHS appear to be doing everything it can to address the enormity of the improper payments issue?
There's always more to do. Any improper payment rate that is as high as it is right now, there's more work to be done.
Specifically, then, can you outline what their efforts have been in the last 2 years?
I can give you a general sense of some places where CMS has moved forward. They have strengthened some elements of their provider enrollment. They've designated risks across the levels of providers, so they have a sense of who to keep the best eye on. Where they need to do more work has to do with fingerprinting those providers, making sure that there's final regulations to ensure disclosure, and then also some core elements for provider compliance programs that would allow them to strengthen more. That's one example.
So I'm just confused. Give me, if I could have another 5 seconds. Fingerprint our providers, our doctors have to be fingerprinted to be, be reimbursed? For
criminal background checks. Mm-hmm.
The gentleman from Texas, Mr. Barton, is recognized for 5 minutes.
Thank you, Mr. Chairman. We've all seen the reports in the last several months about some of these abuses of public funds, the GSA and their trips to Las Vegas, the Secret Service and their escapades down in South America. We all hope that those are exceptions and not the rule, that not everybody in the government behaves that way. But I look at HHS, and by the admission of the Inspector General, he doesn't phrase it quite this way, but it's an agency that's almost not controllable because it's so big. So this subcommittee, hopefully on a bipartisan basis, is going to begin a process to determine what, if anything, that could be done, and if we need to change statutory authority to regain control. Staff has indicated to me that at HHS, this is just a small example, but it's big enough to have significance, that the international, not just the travel budget at HHS, but that the international travel budget is between $56 and $67 million per year, and then it's gone up 15% between fiscal year 2009 and fiscal year 2011. Why in heaven's name, Mr. Cochran, would international travel be over $50 million a year, and why would it be going up 5 to 10% a year? International, this is health domestically, health and human services domestically.
The travel in 2011, as you note, is $65 million. It was $57 million in 2010, $67 in 2009. So it's relative to 2009, it's down just a little bit. But more to your question, the areas within HHS where there's the greatest amount of international travel are the Centers for Disease Control and Prevention, which operates directly funded programs in HIV/AIDS, as well as global immunizations areas like polio, as well as executes on behalf of the Department of State major portions of the President's emergency plan for AIDS relief And the second primary areas for international travel include the National Institutes of Health that do scientific work globally as well, and the Food and Drug Administration.
Could we invite those people to the United States and have them pay their dime to come see us since we were the experts? Do we have to go overseas? I mean, I understand there needs to be some. I'm not saying zero, but you know, if the international travel budget's $50 million a year, it's good to know that it's gone down a little bit. Do you happen to know what the Secretary's travel budget is?
I do not. Would be happy to get back to you on that. The Office of the Secretary overall has a smaller travel budget and especially international travel budget. Within the Office of the Secretary, the main travel costs are our Office of Global Affairs, which again in partnership with CDC, NIH, and FDA helps implement some of our congressionally funded international missions. But I don't know off the top of my head what.
Would the gentleman yield for one sentence?
Sure.
The CDC and the FDA have both made clear their travel budgets are down compared to those of the second term of the Bush administration. So the trajectory is correct.
Well, that's good information, and let's keep it going that way. Let's keep the trend going. That's good to know. I've got 1 minute left. This is a standard question that I ask every agency that comes before us. Mr. Cochran, can you tell me, of the 80,000 employees at HHS, how many of them have a government credit card?
I do not have that information with me or off the top of my head, but we'd be happy to get back to you.
Do you have a government credit card?
Yes, I was issued a government credit card. I myself don't travel. It's not in the nature of my work, so I haven't used it for quite some time, but I do.
So you have one, but you don't use it?
I don't use it often, that's correct.
Okay. Well, if you have it, he should be allowed to use it.
I just haven't.
I want the record to show I have a government credit card issued to me by the United States Congress for travel, and I use it to put gasoline in my leased vehicle, and I use it, as he said, on occasion when I travel domestically outside my district for airfare or hotel. Okay, so I'm not saying it's illegal or immoral to have one, but I am saying that we ought to have an accountability protocol, and most of the federal agencies tend to issue them fairly liberally and tend not to oversee them, if at all. So that's a standard question, and my time has expired, Mr. Chairman. I yield back.
I thank the gentleman. And Dr. Burgess, the gentlelady from Tennessee, Ms. Blackburn is recognized for 5 minutes.
Thank you, Mr. Chairman. I want to thank our witnesses for being here. And I think, as you can hear from the questions that we're asking, it does appear that HHS is now too big to control. And listening to the GAO report certainly lends an understanding of that. You can go look after a couple of programs, but you've got all this other spending that is going on that you can't seem to get your hands around. As Mr. Barton said, the travel budget, and you have to say why. In this time when our constituents are saying the federal government takes too much out of our pockets and it wastes money that we don't have, and it spends money on programs that we don't want. Certainly, there is a disconnect between what the citizens want and what you all think you have the right, for whatever reason you feel entitled, to spend money, the taxpayers' money. Ms. Yoakum, I wanted to come to you. In reading the testimony that you and Mr. Cosgrove had for us today, and in looking at how you've gone in to look at the payments, the fraudulent payments, et cetera, and working with the states, have you all looked at the TennCare payment structure for Tennessee as you've audited the different states?
We have looked at Tennessee with regard to the actuarial soundness requirements for Medicaid managed care, but we haven't done an intensive look at the rate setting methodology itself.
Okay, thank you. I would be interested at some point when you all do that, to know if you do look at that methodology, and since it's one of the early waiver programs and is kind of the test case for what is now Obamacare or managed care, I would be interested to see what you found. I know what my experience was as a Tennessee state senator and how the program failed to live up to what the promises were. Going back to Mr. Terry's question, you mentioned some of the core elements that were needed for some fiscal soundness. Are you looking at implementing new technologies that will help with the tracking and the payments and the disbursements? And is there a way to put some more transparency into this process? Either of you.
I want to make sure I understand in terms of the review of payments
Yes,
within
yes.
within CMS and HHS.
Correct.
Yes,
Correct.
There is I think it's called one IDR, and then a one PI, one Program Integrity, which is a set of electronic review systems that look at claims overall and attempt to combine them. This is important with respect to Medicare and Medicaid to get those claims in one place so they can do reviews and look for indications that there could be improper payments occurring. Yep, okay. Patterns. Yep.
All right, and is that widely used?
It is being used on the Medicare side. Medicaid is not yet up and running. We do have recommendations aimed at CMS putting a plan in place to make this more broadly available.
What kind of timeline is that installation moving forward on?
I think I'm pretty sure that one of our recommendations has to do with CMS developing a timeline. I do not believe at this point they have one.
Okay, thank you for that. Mr. Cochran, I want to come to you on the co-op program that was established under PPACA. OMB says they expect that the taxpayers may lose $370 million in this program from unpaid loans to nonprofit insurers. The estimate is that as many as 50% of the loans issued under this program may not be repaid. Are you familiar with these estimates?
I'm not immediately familiar with the particular numbers you cite. We have them, but I am familiar with the role and the process that OMB goes through for all loan programs to estimate a default rate that they use as a way of scoring the overall cost of the program that then enables HHS to determine the number of loans that can be made within the appropriation that Congress provided.
Well, how can you know that you have them but you're not familiar with them when you're talking about a program that is expected to lose money? How can you be so dismissive of that? I mean, does that not concern you?
It was not my intention to be dismissive. I just don't want to misquote numbers that I don't have in my head, but I do know that OMB plays a key role in setting those default estimates, which then informs HHS on the number of grants that can be made within the appropriation that's provided.
Okay, then let me ask you the question this way. How does stewardship of the taxpayer dollar figure in to the decisions, the departmental decisions on the loans and that you're going to approve or disapprove through this co-op program?
Well, we work with OMB on the establishment of that rate to determine what the default rate would be in order to.
So you are accepting of the premise of default?
In every loan program, there's some portion that for, a variety of reasons.
Okay, then let me, I'm out of time. Can I ask Mr. Cosgrove to follow up on this? Then do you all have any advice for best practices or due diligence that would help them? I find it a little bit perplexing that I have a department with $1 trillion budget. You're flying all over the world. OMB says your loan program is set up to lose $370 million, and you work with them to set a default rate and seem like that's kind of standard operating procedure. Are we missing something in this? Mr. Cosgrove, do you have any guidance that you would provide to him for how they could go about not planning to fail? I want you to succeed when you're dealing with taxpayer money, but let's not plan to fail.
I'm leery about providing any explicit guidance. This is something that we haven't looked at before. You know, we'd be happy to, but we haven't looked at it, so I'm not.
Gentlelady's time has expired. Ms. Christensen, are you ready, or do you want me to take one more on the right side? Okay, recognize Dr. Burgess for 5 minutes.
Thank you, Mr. Chairman. You know, clearly this is one of the most important hearings we will have all year. All of this information is important. I'll never get to all the questions I have. I'm going to submit some in writing. And Mr. Cochran, I trust that we'll get those answers in a timely fashion. That's extremely important that we do. We got some big decisions to make. In your testimony, you talked about unobligated balances, and I must tell you, I'm concerned about that concept of money that was not spent for what it was intended, and now we are using it just within the agency. And the reason it concerns me is, you know, I don't know precisely what the discretionary appropriation was, but for the past 3 years, it's been about $60 to $70 billion a year. So we're looking at a figure around $200 billion. You received money in the American Recovery Act, is that right, in the stimulus bill?
HHS, yes, received appropriations in the stimulus bill. The largest.
Well, the aggregate number. What did you get? It was well over $100 million, was it not?
Yes, some of the major portions were.
$100 million, and in the Affordable Care Act, there was pre-program money coming to HHS for implementation. So, fair to say another $100 million in the Affordable Care Act? I mean, we're looking at $500 billion in discretionary appropriations to HHS in the last 3 years. That's to say nothing of the mandatory money that you get to administer to pay for the programs in Medicare and Medicaid. So this is an enormous amount of money that this agency has. And again, the concept of reprogramming money just bothers me. Either that should offset your next year's appropriation, or it should be paid back to the federal treasury to pay down the year's deficit. Why does that happen?
That is what we're doing with the balances. My reference to using balances as a way to reduce the amount of new resources we're requesting for Congress is specifically in areas where Congress provided them for a purpose, and we're using those balances for that purpose.
Okay, here's the problem that we have. It was pretty much in evidence on this travel question that came up. Look, I get the fact that if the CDC did not go over to Geneva and literally run the World Health Organization, an outbreak of a deadly disease could be a serious problem on American soil. So I get the fact that that's important. But we have no level of detail. When we ask for your travel budget, it's, you know, here's this volume of dollars that's given. We really need the breakdown. How much travel was for CDC? How much was for HRSA? HRSA got no business going other places in the world. So if they have a travel item, an international travel item, that may be a red flag that this committee would want to know. You have, and this has been, I'm not picking on you because this has been a historic problem in Health and Human Services and the EPA, trying to get the level of detail in a budget, a balance sheet that any private corporation could provide us if we were to ask it of them. You guys can't do it. And I've had this discussion with Mr. Larson at CSIO. We need a level of detail when we ask for budgetary information. So I am going to ask you, I don't expect you to have it today, but I'm going to ask you for the line item budgetary information on these reprogrammed or unobligated funds, and whether they were stimulus monies, PPACA monies, or just regular discretionary appropriation monies, because, again, we can't know how to help you until we really understand where the problems are. Now, Mrs. Yoakum, you referenced, you made a statement about the improper payment rate as high as it is now. How many dollars are we talking about in this improper payment rate?
I'm not sure I can give you a specific.
Well, get one for me, because I would like to have it, because its improper payment rate makes a big difference. We're struggling with what to do with a sustainable growth rate formula. We'd like to be able to offset that if there is a 10-year budgetary window that equals or surpasses the amount of money it would take to replace the sustainable growth rate, we could solve a huge problem in Medicare, a huge problem for HHS. Why can't we have that information so we can solve that? Now, you referenced also the concept of the or I guess Mr. Cosgrove, it was you when you talked about a red flag when billing reaches atypical levels. Did I hear you right when you said that?
That's correct.
So in other words, when the money going out the door is just clearly a red flag or an outlier, CMS should be able, or HHS should be able to say, uh-oh, we got a problem here. Is that correct?
That is correct. I mean, we're recommending that they increase their ability to look for patterns so that...
Okay, here's a pattern for you. More money spent on cosmetic braces in the state of Texas in Medicaid dollars than the rest of the country combined. How's that not a red flag? What are all these great metrics that have been put in place? And you didn't catch this was 2 or 3 weeks ago. I mean, these guys are laughing at you. You have got to do a better job with this. I know my time's expired, Mr. Chairman. I hope we will have an opportunity to go to a second round because this information is so critical. But I know Ms. Christensen just got here, so I'll yield back.
The gentleman yields back. Ms. Christensen, you're recognized for 5 minutes.
Thank you, and thank you, Madam Chair. We all recognize that we're in fiscally challenging times, and the responsibility to ensure that we are making financially sound decisions is shared by all of us. But when it comes to health and healthcare, making financially sound decisions is more complicated than just slashing budgetary line items based on a price tag without any consideration really given to the long and even the short-term economic consequences of those decisions. So, Madam Chair, if we want to talk seriously about decreasing the long-term healthcare spending, we should talk about the cost controls in the Affordable Care Act and how we can build on them. So I'd like to ask the witnesses some questions about just how we do that. Mr. Cosgrove, would a system that truly rewards doctors, for example, for quality and which decreases financial incentives to deliver unnecessary care, would that decrease Medicare costs?
That's definitely the direction that we need to be moving in. Right now we have a system that pays for volume of services, and the more providers do and the more expensive services they provide, the more they get paid, and that's the wrong incentive.
Right, and thank you. And the Affordable Care Act takes a big step in that direction with a number of delivery system reforms in order to make Medicare and, in time, the broader healthcare system pay for value. It develops accountable care organizations, so Medicare will pay one provider to coordinate all of us seniors' care rather than paying many providers, no matter what the cost. It experiments with bundled payments, so Medicare would pay a lump sum for quality care rather than separately for each treatment. And it also, within the Affordable Care Act, implements the Independence at Home demonstration project to bring home-based primary care to some of Medicare's sickest and most frail seniors who are unable to make it to a doctor's office. Mr. Cochran, these delivery system reforms in the Affordable Care Act are they projected to reduce the growth of Medicare expenditures?
Yes. The
accountable care and...
Yes, there are a number of quality provisions in the Act. There are payment reforms in the Act. There are program integrity reforms in the Act that, on total, I believe CBO extended the Medicare solvency from 2016 to 2024.
Right. In fact, the Budget Office, the Congressional Budget Office, has estimated that the Affordable Care Act will reduce the federal deficit by $210 billion this decade and more than $1 trillion in the following 10 years. And these are significant cost savings. We should be talking about how we can build on them instead of repealing the Affordable Care Act as the House Republican budget does. And Mr. Cochran, can you talk about what CMS is doing to make Medicare more efficient and save federal dollars?
There are a number of things that CMS is working on. The area of quality, there is a national initiative known as Partnership for Patients that's designed to improve safety and reduce readmissions, which both improves the quality of health as well as saves costs. There is a value-based purchasing effort to reward quality and efficiency in hospitals, as well as public transparency efforts to provide more information about quality for nursing homes and other providers and as well as accountable care organizations that are just being launched to encourage coordination and prevention of care and bring down costs and improve quality.
Thank you. These are all important steps, Madam Chair. These reforms all have one thing in common. They save taxpayer money and improve the quality of care without shifting costs to seniors or eroding the core basic benefits of the Medicare program. And this way they stand in sharp contrast to the Republican budget. There's always a right way and a wrong way to cut the federal budget and reduce health care costs, and the Republican budget is exactly the wrong way. Mr. Cochran, I think I have a little more time. I wanted to ask you another question. The Joint Center for Political and Economic Studies released a report a couple years ago that found that eliminating racial and ethnic health disparities could save the nation $1.24 trillion in direct and indirect medical costs just over a 3-year period. In your testimony, you mentioned that one of your many responsibilities was to investigate a mix of investments that will improve the health and well-being of the nation in a cost-effective manner. So given the extremely high cost we absorb every year that racial and ethnic health disparities are not eliminated, don't you think that the national strategy that the Department of Health and Human Services has developed and is implementing right now is another component that would help to achieve the larger objective to improve the health and well-being of the nation in a cost-effective manner?
Yes, the work that our Office of the Assistant Secretary for Health and some of our key operating divisions are doing both to develop and implement the strategy is important, as is the investments that the President's budget proposes in key areas, including the Indian Health Service that I mentioned earlier, the Ryan White HIV/AIDS program, including for drug treatment, as well as a number of programs across HRSA and CDC that target those populations that are most vulnerable.
Thank you. Thank you, Madam Chair.
And recognized for 5 minutes, the gentleman from Louisiana, Mr. Scalise.
Thank you, Mr. Chairman. I appreciate you having this hearing, as we've had a number of hearings on the budgets of various agencies and the things that we're trying to do to control spending in Washington. And unfortunately, we don't have enough people in Washington that are serious about controlling spending, and that's why we've got over $1 trillion deficit again. And so I think it's important that we look at the budget and scrutinize and ask some of the questions that our members have been asking. Mr. Cochran, HHS has requested $1 billion in additional funding to implement the President's health care law, and that's in addition to the $1 billion that's already been appropriated for implementation when it was originally enacted in March of 2010. Why, first of all, why the need for an additional $1 billion on top of the $1 billion that was already in the original bill?
The original billion, as you know, does include, the original bill, does include $1 billion. The Congressional Budget Office initially estimated that it would cost roughly $1 billion per year to implement the act. We have to date obligated roughly half of that $1 billion. The 2013 budget projects using the remainder this fiscal year in 2012, and the investment in 2013, the proposed increase within the Centers for Medicare and Medicaid Services is to continue that effort. A major component within that request is to launch the health insurance exchanges, and there's a need for investments in 2013 in order to launch the exchanges in 2014, after which time they largely become self-sustainable.
So where did you get this $1 billion from? Did you just redirect it from other parts of the HHS budget? You had $1 billion that was literally just lying around to go and take and move to put in the area of the funding for Obamacare that was under, I guess, under anticipated.
The original $1 billion that was in the Affordable Care Act, or the $1 billion proposed?
The additional $1 billion that's proposed. That's been requested, yeah.
So in formulating the annual budget, we go through each operating division, and we work closely with the Office of Management and Budget to identify savings, both to reduce the deficit overall, but also to fund priority areas. We've identified roughly $2 billion in savings across HHS in our discretionary budget, which enabled us to invest proposed investments in the Indian Health Service, biodefense preparedness, as well as CMS.
Have y'all ever thought about investing in reducing the deficit? If you've got too much money in your budget and you've gone through and you've identified areas where you can achieve savings, you know, because one of the things I'm looking at, the president issued an executive order directing y'all to establish a plan to reduce 20% below 12 levels for costs associated with travel, employee information technology, printing, other things. From what we're looking at here, the quote-unquote savings that you identify here, it looks like you're using those to spend in other areas to absorb cost increases. So are you actually saving in terms of reducing the deficit, or just moving money from one area of your budget to another area of your budget to keep spending at the same levels?
The President's budget includes savings, so the 2013 President's budget includes savings of over $300 billion on the mandatory side by slowing the rate of growth in...
so not actual cuts, you're just slowing the rate of growth, you're not actually reducing from prior levels.
It's reductions relative to the baseline that CBO establishes, and then on...
Right, and I mean, you know, in Washington, unfortunately, people use a different set of languages than American people use across the country, our small business owners, families. You know, when they sit at their kitchen table and they say, we got to balance our budget, we've got to cut because we have less money this year, they don't say, well, instead of having a 10% increase, we'll just spend 5% more and call that a cut. They don't call it a cut. A cut means if you were spending $50,000 one year and you got $45,000 the next year, that's a cut. You know, you don't say, well, we had $50,000 last year, we're going to get $55,000 next year, and so that's a cut because we wanted 60. And so I know it's kind of chic to use that around here, but you know, people back home don't get it when they hear, well, wait a minute, the agency's actually got more money, and they're talking about how they reduced spending and they had less money than the proposal from the president's request. It's still more money. And they want to see, when we're, again, borrowing $1 trillion more than what we're spending. I want to ask a couple of questions as I'm running out of time. You know, I think some of the other members had asked some questions about travel and even fleet vehicles. If you can just get the committee the number of vehicles that y'all have that are assigned to employees that they're able to take home. Can you get the committee that number, how many vehicles HHS has throughout the agency that are allowed to be taken home by employees?
I can tell you that across HHS, our Program Support Center carries these statistics and reports. There are 4,900 vehicles across HHS. Those aren't all for the purpose of you know, executive travel or vehicles that someone would take home necessarily. They're primarily in the areas of for delivery, you know, movement of providers in the Indian Health Service.
And I'm not asking you to give me the number. If you have the number here right now, that's great. But if you don't have the number, can you get the committee that number, the number of vehicles that are allowed to be taken home by employees?
Yeah, well, I can tell you that we have...
it's a yes or no question. I'm just asking if you can give me that number.
I will certainly work. I guess my only hesitation is I'm not sure how we have the data in terms of whether it's coded as
you're not sure if you know how many people are taking home vehicles?
No, we know that there are 4,900 vehicles. We'll do our best to provide the information you're requesting.
Okay, and if you can do the same thing on we've talked about travel a bit, you know, and looked at the numbers on international travel. Can you get me within the travel budget how much was spent on first-class travel? Because there have been some outside reports that have looked at tens of millions of dollars of cost savings we can achieve just by having government employees, when they're flying on the taxpayer nickel, to fly coach, not economy, not business class or first class. And so if you can give me the amount of money that's spent on either first class or business class travel, is that something you can get the committee?
We will work toward that. Travel overall, we're reducing by 17%, and the vast majority of travel is coach now. I don't know that there is much first class or business.
Some outside agencies have looked at, some outside groups have looked at this and seen tens of millions of cost savings that they could achieve, and I'm sure your agency is one like most agencies that have the ability to do that. I'm just asking if you could get us that information.
Gentleman's time has expired.
Thank
if
you,
you could accommodate him, that'd be helpful. We're going to do a second round of questioning, and I'll start out, Mr. Cochran. There's a Health and Human Service executive order. It's 13589. it proposed just under $900 million in cuts to administrative expenses. Is that true? Does that ring a bell?
Yes, sir.
Yes, sir, okay.
The HHS target is $876 million.
Okay. And it's noted in the budget of FY 2013 that, quote, agencies are redirecting some savings to absorb other cost increases and fund priorities activities. Isn't that correct?
In some areas, our budget requests have come down.
Yes or no, that statement, is that correct? That you're, in fact, in your opening statement, you said, we're seeking opportunities to make investments today that will yield greater returns in the future, such as the healthcare fraud and abuse control system has returned. In other words, what I'm saying is that you've indicated that your agencies are redirecting some savings that you find here elsewhere. Isn't that true?
In some cases, that's correct. In other cases, we have reduced agency budgets, and that was made possible by administrative savings.
Okay, so I guess what we're concerned about, that are you taking this Executive Order 13589, where you have roughly $900 million in savings or cuts in administrative expenses, are you considering that savings that you are redirecting elsewhere into other government programs? Is that true? Is that what's happening?
In some areas, take, for example,
so
the
National Institutes
of Health, where we're investing that
so the answer would be yes.
Research.
I mean, some, but the answer would be, some would be yes. In some cases, you're taking the so-called cuts and you're funneling them into other areas, and you're considering them savings that you can use elsewhere. I'm just trying to show to the committee here that the impact of these cuts are going to obviously be significantly less. If you take that $876 million that your savings in administrative costs and you're funneling it into another program, that there won't be any savings. Let me move on to the next question. You're aware that Health and Human Services has the most highly paid civil servants anywhere in the federal government. Would that be yes? That'd be a true?
Health and Human Services is subject to the same general schedule rules of all.
Well, let me just say the fact is you have the most highly paid civil servants anywhere in the federal government. For example, over 90 of the 100 most highly paid civil servants anywhere in the federal government work for Health and Human Services. And these 90 are capped at $375,000 a year. Isn't that true? The cap is $375,000 a year?
That's in reference to a specific, what's called Title 42 authority.
The answer is yes. Yes, they have a $375,000 cap. That's true. That's correct, isn't it?
Under one specific authority.
Right.
Most HHS employees are under the same authority.
And over 650 of the federal government's 1,000 highest paid civil servants work at the Health and Human Service and its component agency. Isn't that true?
The majority of the Title 42 employees that are under a different authority for a different salary level are at the National Institutes of Health, and they're primarily scientific positions in.
Well, we have them including in these high-paid salary people are in CDC, FDA, the Indian Health Service, and NIH. Isn't that true? Where most of these highly paid civil service are? Isn't that true?
Yeah, the largest number are at NIH, referenced Indian Health Service. There are some providers, medical doctors.
Okay. And in 2009, more than 530 NIH employees appear to have earned salaries of over $200,000 above, and that's more than the president's own cabinet. Isn't that true?
Under this particular authority, the vast majority of HHS employees are under the same system.
So I think the dichotomy here is that the cabinet officials are getting less than 530 of NIH employees, and then if you look at the salaries of these 90 of the most highly paid, which have a cap of $375,000, you see that these people are getting well paid even compared to some of their colleagues here, not to mention how they're well paid compared to the private sector. My last area of concern here is let's see. We have the Health Reform Implementation Fund. The President proposed an additional $1 billion in discretionary funding for the implementation of the PPACA through the Center for Consumer Information and insurance oversight at CMS. As of January 31st, we have some figures here that stop at January 31st, 2012. I guess the question is, can you update this graph to take us up further beyond January 31st?
Yes, sir.
Yeah, okay. Mr. Cochran, now how has CMS used its resources from the implementation fund since January? Can you tell us that? Although we don't have the data, can you just maybe bring us up to speed? And how much of the fund remains?
The fund is of the $1,471,000,000 has been obligated as of February 29th. Some of that is for personnel, more of it is for contractual services, and the expenditures have been for closing the Part D coverage gap. That's one of the key provisions in the Act, as well as developing the new value-based purchasing models for Medicare providers that we talked about earlier, as well as helping plan and prepare for the establishment of the state and federal exchanges.
All right, my time has expired. Ms. Schakowsky is recognized for 5 minutes.
I wanted to just set the record straight on a couple of things regarding the salaries under the Title 42 program. Dr. Harold Varmus, the director of NIH under the Bush administration, who now runs the Sloan Kettering Cancer Center, said, quote, "If we don't pay enough to keep the best, we condemn ourselves to mediocrity." So my understanding, Mr. Cochran, is we're trying to at least keep competitive to hire scientists that are required to have doctoral degrees in order to receive those high salaries. Is that not true?
Yes, that's correct.
Okay. I also wanted to put into the record, Mr. Chairman, this is an article from Health Watch, the Hills Healthcare blog. Quote, "House Republicans who say taxpayer funds went to spay and neuter dogs in Nashville have the story wrong. Quote, there was a spay and neuter clinic, but it was funded by a PetSmart Charities grant to the Nashville Humane Association," said Alyssa House-Shalter, whose job includes directing a federally funded program in the city known as the CPPW. That's the one you were referring to here. So maybe that entire program, it says, as a partnering agency, we would have had staff members that were there greeting people at the event and so forth, but the funding was not from us. So I'd like to put that in the record.
By unanimous consent, we'll also, if you have no objection, put in these two flyers that I've given you, the one on the temporary veterinarian clinic initiative as funded in part by the Department of Health and Human Services as part of the Metro Public Health Department's Community Putting Prevention to Work campaign, which shows and corroborates that, together with these two web pages, which also corroborate. We'll put both of them in.
Okay.
By unanimous consent, so ordered.
Okay. I wanted to talk about the Republican budget priorities and women. From Medicare and Medicaid to the Prevention and Public Health Fund, HHS is responsible for programs that millions of women rely on for critical health care needs. And I want to talk about some of the drastic changes to these programs that my Republican colleagues have recently endorsed through the budget and appropriations process. The House Republican budget would turn Medicaid into a block grant, repeal the important new benefits under the Affordable Care Act, and cut federal funding for Medicaid by a staggering $1.7 trillion over the next decade. Mr. Cochran, am I correct that Medicaid covers more than 40% of all births in the United States?
I don't have that statistics with me, but that sounds roughly correct.
So what Medicaid does is it offers a solution for low-income pregnant women who can't afford private insurance by covering maternity and prenatal care. Dramatic cuts to the program truly would have a disastrous effect on women and their children. The Medicare program also provides important benefits for women. Mr. Cochran, am I correct that 56% of all Medicare beneficiaries are women?
That sounds correct. Again, I'm sorry, I do not have that data with me.
Well, the House Republican budget ends the guarantees we've made to our seniors by turning Medicare beneficiaries over to private insurers. It shifts costs to seniors. In fact, CBO has said that by 2030, beneficiaries could pay up to $2,200 more because of these changes, disproportionately falling on women because they have longer life expectancies. I'm looking at you, Mr. Cosgrove. Did you want to say something in this regard? Were you?
No, I'm simply acknowledging the fact that women do tend to live longer, and so especially on the Medicare program, you do expect to see more women as more older women of the oldest old, too.
Thank you. Mr. Cochran, can you tell us the purpose of the Prevention and Public Health Fund?
Yes, the Prevention and Public Health Fund, the primary purpose is to support programs, activities, interventions at the state and local levels to prevent chronic disease, to reduce the use of tobacco, prevent obesity, help communities target health issues in their area. It's also being used to support childhood immunizations, as well as some activities in the infectious disease area like hepatitis C.
And isn't it also true that $140 million from the fund goes toward breast and cervical cancer screening services?
As proposed in the 2013 budget, the fund will support those activities, yes.
Which would help pay for 326,000 women to get breast cancer screening and for 284,000 women to get cervical cancer screenings, and Republicans are voting to take it away. And Mr. Chairman, I would just say this is a sad example of how the Republican budget is dangerous for women. And I yield back.
The gentlelady yields back. The gentlelady from Tennessee is recognized for 5 minutes.
Thank you, Mr. Chairman. And Mr. Cochran, I wanted to come back to you if I could. In my opening statement, I mentioned that I wanted to hear from you regarding the steps that you all had taken to comply with the President's call for agencies to identify $100 million worth of savings. Are you able to articulate that list, or do you have a list?
Yes, we have identified, at that time, we identified savings in the area of data centers at CDC and FDA, as well as the migration from paper to electronic filing, primarily at FDA, as well as at CDC and ACF. In addition, we've subsequently identified.
Okay, hold on just a moment there. So you've identified CDC, FDA, and the paper to electronic filing. So what portion, how much money from each of those?
Well, for the President's executive order in these administrative areas, we're reducing spending by 21%.
And the budget was increased how much prior to your making this reduction?
The 2013 budget it's a decrease of $218 million. It's roughly flat on the discretionary budget.
Your 2010 budget and the stimulus funding was a good percentage. I'll get that number for you so that you have it. I don't have that exact number in front of me. So if you could submit in writing the answers to that list, that would be very helpful for us. We want to be able to see what you all have done to actually make these spending reductions and to live that out. One other question for you along the same line. We're working through reconciliation, looking at the sequestration and reconciliation. So what are you all at HHS doing to prepare for reconciliation and the reductions that are going to come?
Well, prepare for reconciliation or for sequestration? For sequestration, the administration's position is that the 2013 budget provides specific savings proposals that, if enacted, would enable us to achieve the reductions to the deficit without relying on sequestration.
Okay. So you feel like you're ahead of the game?
Well, the President's proposals overall, including HHS and other departments, would enable savings, specific reductions.
Let's do this. Why don't you submit in writing what you all are doing to make preparations to meet the sequestration numbers and to meet the reductions, that we're going to continue to bring forward. May I remind you, you're an agency that, as we read your reports and as we hear from your Inspector General, who should be here with us today and is not, and as we listen to GAO, it is very evident to us that you all are too big to manage. You have gotten too unwieldy. You are into areas where you should not necessarily be. You are spending money in ways that you should not, ought not to be spending it. And it is our responsibility to come back and to exercise some oversight on that. That is what we're doing here today. And I know that maybe you weren't provided all of the information that you needed to have to handle this hearing today. But even if you were not properly given the information, with all due respect to you, let's just be sure that we submit all of this in writing, because it's something that is important to us. It is important to our constituents. It is important to the hospitals and to the providers that serve all of these individuals that walk through their doors every day wanting health care. And we come up here and we talk to you all, and we see a lot of the money that ought to be going out there to individuals, to enrollees, to the healthcare system is spun up, tied up, wadded up over here in HHS, and it's something that we want to get our hands around and help you all be more efficient and do a better job for the taxpayers. And I yield back.
The gentle lady yields back. The gentleman from Ms. Christensen, I'm glad you're here. Thank you. You're recognized for 5 minutes.
Thank you, Mr. Chairman. Before I ask my questions, Ms. Yoakum and Mr. Cosgrove, I wanted to just highlight on page 5 part of your testimony on aligning coverage with recommendations of the U.S. Preventive Services Task Force. I'm sure you're aware that there have been several recent recommendations coming from that task force that not only I, but others consider questionable. And they don't take into account some of the outlying groups like racial and ethnic minorities. For example, in the breast cancer recommendation, Black and Jewish women are at risk for breast cancer at early ages. Didn't seem to take that into account, and it didn't take into account the high prostate cancer incidence in African American men and with their recent prostate screening recommendations. So I at least think that to tie reimbursement too tightly to all of their recommendations can be harmful to some groups in our population, and would deny them access to some needed care because they won't be able to afford it. So I don't know how you address it, but I wanted to call your attention to that because some of their recommendations are very questionable and really don't take into account the entire population in the United States. Go ahead.
No, I just want to say that CMS has the authority to consider the recommendations from the task force when they're making coverage decisions. We didn't independently, because of that authority, we didn't independently go on and have experts that would look behind the task force recommendations.
But you still recommend that CMS provide coverage for task force recommendation services. You do say as appropriate.
Correct.
But, okay.
Right.
Thank you. But, I listen to my Republican colleagues, and HHS houses agencies that Americans rely on every day to protect their health and keep them safe, like the FDA, National Institutes of Health, Center for Disease Control. The House Republican budget would result in drastic cuts that undercut the essential functions of these agencies, and I want to explore some of the implications of those cuts. So, Mr. Cochran, my understanding is that the Republican budget would make across-the-board cuts in discretionary spending. Is that correct?
There are across-the-board cuts associated with sequestration that are, CBO estimates at roughly 8%.
But they're going beyond that.
The House the House Budget Resolution does set spending levels, not specific to HHS, but government-wide, that are below those established in the Budget Control Act for 2013-2014.
Right. And am I correct that this discretionary spending is what provides a significant amount of budget to the agencies like the Food and Drug Administration, NIH, and our new Institute of Minority and Health Disparities, and CDC?
Yes, the majority of resources for our discretionary agencies outside of the entitlements is regular budget authority. Almost all of NIH's budget is provided that way. FDA is supported by a combination of budget authority and user fees from industry.
Yes. So to single out just one, can we talk about what FDA's essential functions are? Can you talk to us about what their essential functions are?
Yes, FDA, their mission is to protect the public's health by assuring the safety, the efficacy, the security of human as well as veterinary drugs. They work on biologics and devices. They also work to protect the U.S. food supply. They have a new responsibility over the regulation of tobacco products to reduce youth smoking. And they are working to accelerate the review and approval of medical countermeasures to protect the public against bioterrorism attacks.
Right, and these cuts would jeopardize the safety of our drugs, our vaccines, and medical services. And then at NIH, the Center of U.S. Medical Research, one of the greatest research institutions in the world, but that Republican budget would mean that NIH would have less money available for cutting-edge research into breast cancer, HIV, Alzheimer's, and health disparities. So how much funding does NIH currently receive to conduct scientific research?
NIH's budget is $30.7 billion.
Thank you, and we know that that money is well spent. As a matter of fact, they could, I believe it's level funded in 2013, and that does not allow them to really make the kinds of research investments that they need. Their studies have led to development of the MRI, how viruses cause cancer, the mapping of the human genome with all of that is going to lead to. And they boost our economy through medical breakthroughs. According to one study, for every dollar of public funding for scientific research, the drug industry gets a $3 return. So deep cuts to NIH would be an irresponsible fiscal decision. But, so I appreciate your helping to explain the impact of the Republican budget, not just on Medicare and Medicaid, but on other important government programs. So thank you for your testimony and your answers.
I thank the gentlelady. I would say that we're trying to control the budget. We'll have to do some cost cutting somewhere if we're going to do that. The gentleman from Texas, Dr. Burgess, recognized for 5 minutes.
Thank you, Mr. Chairman. And I do want to go on record to say there's been no bigger critic of the Title 42 program than myself, but I understand the necessity of having a Title 42 program. If we have the best virologist on the face of the earth, we want to be able to pay him or her an amount commensurate with their ability. If we have the person who sequenced the human genome working at NIH, we want to be able to pay him or her to a degree commensurate with their ability. But we don't need to be paying entry-level biologists and chemists. And I won't say that HHS has been as guilty of that as EPA has been over the years, but it just points out that this committee must have oversight. If we are willing to spend more money to have top researchers in their field, we must have oversight into how those dollars are spent. Off the editorial statement now, let me just ask a question, Mr. Cochran. Dr. Christensen, very critical of the budgetary process, okay within her purview to do that. You may have heard or read in the papers, the Supreme Court heard oral arguments about the Affordable Care Act at the end of March. Did you read about that?
Yes, I'm aware.
And then there was a lot of chatter afterwards that maybe something might happen to the Affordable Care Act. Can't know, won't know for another 6 weeks. But are you doing anything within your agency to prepare for the Supreme Court voiding a portion or all of the Affordable Care Act?
The HHS, again, principally the Centers for Medicare and Medicaid Services, as well as other components, are focused on implementing the act, which is law, the law of the Congress.
Focused? They're going at light speed. I'm sorry, continue on.
And I mean, I'll stop there. That's where we're putting our attentions is to carry out.
So
the law.
there are no contingency plans. Whoa, what if this thing gets struck down by the highest court of the land?
The focus is on implementing current law.
So the answer is no, there are no contingency plans. We are not paying attention to current events surrounding our agency, and if the world comes crashing down around our ears on June the 30th, so be it. Is that the statement? Is that what the impression you wish to give the committee?
I wouldn't phrase it that way. I would say that we are
I'm trying to help you.
Yes. That we are focused on implementing, the CMS is focused on implementing the Act, its current law, and that is where work is.
So by inference, there are no contingency plans, and if your world comes to an end, so be it. Well, let me just ask you this. We've heard all this great testimony about all the wonderful tools you have under the Affordable Care Act for combating fraud and waste. A lot of those just sound like good management practices, and I suspect a lot of those were going on, and we could study GAO reports from previous years and find that many of those things have already been going on. But if there are specific tools that you were granted under the Affordable Care Act, what happens July 1st if the Affordable Care Act is no more? You stop prosecuting fraud in the Department of Health and Human Services? Do you just give up?
CMS, our Office of Inspector General, DOJ, they have the CMS, for example, have tools that have been enhanced through the Affordable Care Act, but they have been working in this area for a long period and have funding and authorities that preceded the Act.
So you wouldn't just throw up your hands and say, we give up, fraudsters win, and we're going to just hand the money over to the crooks, right?
This is one of the highest priorities of the department, and it's an area of great focus. And
so the loss of the Affordable Care Act would not inhibit your abilities to fight fraud. Is that correct? Is that a fair statement?
The law provides CMS with additional authorities that have enabled them to, that are enabling them to do a better job to
but you would, if I may, you wouldn't grind to a halt on July 1st or 2nd if the Supreme Court so rules.
But there are authorities and funds that precede the Act, and it is a major area of focus, a major priority for the department.
Well, again, suffice to say, fraud enforcement is not going to go away if the Affordable Care Act is struck down by the Supreme Court. You and I don't know the answer to that at this point, so it's obviously a point of some conjecture. What's not a point of conjecture is the sequestration that is going to happen. I have to tell you, I was a little disturbed by your answer to Representative Blackburn's questions about sequestration. You're giving us the impression that the President's budget for 2013 actually included those sequestration cuts?
I'm sorry, no. The President's budget includes specific targeted reductions that would make sequestration unnecessary to achieve the same end. Sequestration is an approach of across-the-board reductions for all activities.
Wait, sequestration, you can't just say it's not necessary. I mean, it's a law. The President signed it. Surely he remembers that.
And the policy of the Office of Management Budget of the administration is to work with the Congress to find specific reductions and avoid a across-the-board approach to finding savings.
Well, okay. Sequestration starts when? January 1st of 2013? And what are the efforts that are ongoing now in working with the Congress to identify? You've got 8% of your discretionary budget, if I understand things right. Does that sound right, 8% that you have to cut?
CBO estimates, right, just roughly 8% would be not just for HHS, but across discretionary spending, non-defense discretionary spending.
Well, that's a lot more than the reductions that are proposed in the President's budget for 2013, correct?
That's correct. The President's budget proposes a mix of, and not just in HHS, but government-wide, a mix of discretionary reductions, mandatory reductions, and other,
well, correct me if I'm wrong, but the way the law reads, the law that the President signed is the sequestration comes from HHS, right?
No, the law enacted created a committee to find specific savings. Sequestration was a backstop to that. The administration's position is to
yeah, that was a super committee. They failed. We all got that. They fell to earth. So January 1st, you've got to come up with 8% in cuts in your agency. How are you proposing to do that?
The way sequestration is modeled is to have a strict across-the-board reduction as opposed to the targeted savings that the administration's budget proposals would.
And are you preparing for those across-the-board reductions within your agency? You're the budget director, right? Or the assistant budget director?
I am, and the focus is on working with Congress to identify specific reductions as opposed to relying on across the board.
So what specifically have you done to work with Congress? You got 6 months before this thing kicks in. Mr. Chairman, I beg some indulgence. You've given other people extra time. This is of critical importance, and this committee needs to know.
Gentleman asked for unanimous consent for another 30 seconds.
Right. Could the gentleman please answer the question? What have you done to work with this committee, this Congress, in order to avoid that 8% across the board reduction that you're going to see January 1st?
Well, the President submitted a budget in February that has a number of proposals and seeks to work with the Congress to have those proposals be enacted.
In all due respect, that budget was pure fantasy. It did not garner a single vote on the House of Representatives on either the Republican or Democratic side. I think we're going to have to do better than that. Would you not agree with that?
I would agree we have a long way to go. And
so what is your proposal to work with this committee and Congress to avoid the sequestration across the board cuts, to identify those areas of savings and or cuts that can occur?
Well, gentleman's time has expired. You're welcome to answer the question. And if you can't, perhaps you could come back and provide us written material.
Either way, our jurisdiction is just within the Department of Health and Human Services, and we have proposed over $300 billion in specific reductions on the mandatory side, as well as specific discretionary reductions. We've briefed the appropriations committees on the discretionary budget. And
would the gentleman from Texas like to go a third round? Because we can do that.
Yeah, I would be happy to.
We can. I'm not sure we'll all use it, but I think I'll take a third round, and perhaps the ranking member, and then we'll come back to the gentleman. He may not need his full 5 minutes. I think the point that the gentleman from Texas is making is pretty important here, and I think as a subcommittee and oversight, we should have an understanding of what's going to happen with sequestration. The Impoundment Control Act and the Anti-Deficiency Act are going to complicate the budgeting process for your department. I think we all agree. The act includes two main prohibitions. One, agencies can't spend more money than they have or spend money before they have it. And two, agencies cannot accept voluntary services. On the other hand, the Impoundment Control Act requires that agencies obligate the amount that Congress has appropriated. So in anticipation of the sequestration, what is the department's plan to prevent violating these two laws?
For our discretionary budgets, has particularly in recent history often been the case that at the beginning of the fiscal year we're under a continuing resolution where we don't yet know what Congress will provide for that full year, and in those situations we operate at a lower level with respect to not releasing all grant funds. In particular, and in this case, under a continuing resolution in the fall and leading up to January would take the same approach.
Mr. Cosgrove, and do you have any comments that you might have relative to the sequestration and what Mr. Cochran has said?
I don't specifically. My understanding is that agencies would need instructions from OMB, and that those have not been provided, but I'm not an expert on the sequestration law.
Ms. Yoakum, do you have anything you might add?
I don't. No.
Okay. Mr. Cochran, what percentage reduction amounts of cuts would hit HHS discretionary budget authority, for example, on NIH? Do you have any feel for that?
Under sequestration?
Yeah.
CBO estimates sequestration would be roughly 8%, 7.8%.
And that would be true on CDC too?
For the majority of funds, yes.
FDA?
For the majority of funds, yes.
Yeah, okay. All right. I think that's going to conclude my comments. Ms. Schakowsky?
Thank you. I wonder if the gentleman and all those so interested in what HHS is doing to prepare for sequestration are equally as committed to the requirements for the defense budget under sequestration, which would have been protested from day one on the Republican side of the aisle, and have looked at the prevention fund as a way to help avoid cuts in the military on the military side. I also, all this focus, which I agree, we want to cut all waste, fraud, and abuse. We want to be absolutely efficient. And that, frankly, is why we passed the Affordable Care Act, or as I fondly call it, Obamacare. Is it not true, Mr. Cosgrove or Ms. Yoakum, that the projection in savings under the Affordable Care Act is $210 billion over the next 10 years and $1 trillion over the 10 years after that, that repealing it would in fact raise the deficit?
CBO did estimate savings associated with the passage of the act. Yes, that's correct.
At the same time, the Republicans, added a $400 billion drug benefit program, unpaid for, and with a prohibition that Medicare could even negotiate with the pharmaceutical companies for lower prices, and have consistently opposed efforts to reduce the Medicare Advantage overpayments to insurance companies. So, I'm willing, more than willing, to roll up my sleeves with you and with HHS to figure out the ways that we can achieve needed savings in our healthcare spending. But I just really find offensive the selective criticisms. I want to repeat that the travel budget is down from the second year of the Bush administration, that they see a 17% cut, further cut. I don't object to asking for the details, but to the affect here in that somehow there's a disregard for saving taxpayer dollars, I think is really misspent. In fact, I think we can look at how the Republican budget would increase Medicare fraud, and I want to ask a couple of questions about that. The Republican budget in repealing the Affordable Care Act, which contains significant new tools for fraud detection and prevention, new resources to fight Medicare and Medicaid fraud. And so while Dr. Burgess was saying you're going to still fight fraud, but doesn't the Affordable Care Act give you new tools to do that, Mr. Cochran?
It does.
And what is the typical return on investment for every dollar spent on Medicare fraud?
The return on investment for the last 3 years for our healthcare fraud and abuse account has been 7 to 1.
And would these significant budget cuts and eliminating the new authorities given to HHS to prevent fraud before it happens impact your agency's ability to fight fraud?
CMS is finding the new authorities to be helpful in moving away from what is sometimes called a pay and chase and toward being able to suspend payments before they are made whenever there is an investigation of a credible allegation of fraud. The resources that the Act provides are important for not only the work of CMS as well as our Office of Inspector General and our partnership with the Department of Justice.
And the Republicans' budget impact on preventing fraud in the Medicaid program would also be profound. The Republican proposal to turn Medicaid into a block grant would result in dramatically decreased federal contribution to state Medicaid programs, a cut of more than $810 billion over the next decade. And Mr. Cochran, wouldn't such a dramatic cut on the federal contribution mean that states' anti-fraud spending would be increasingly in competition with their spending on patient care?
In the context of reduced resources, that trade-off is I think could be is logical to expect that sort of trade-off. The emphasis of the administration on Medicaid is to find specific reductions and to retain its core function as a specific benefit for low-income populations.
Well, I think this is a powerful example of why the Republican budget is so misguided. It is penny-wise and pound very foolish, making cuts that would result in increased Medicare and Medicaid fraud and cost taxpayers more in the long run. And I yield back.
Lady yields back. She's one of the first Democrats to use Obamacare in a way that she's proud of, and I think that is something. I would say to her that the cost savings that she talks about obviously come from the reduction in Medicare by $500 billion. So with that, Dr. Burgess is recognized for 5 minutes.
Thank you, Mr. Chairman. Mr. Cochran, a former member of Congress, Charles Stenholm, Democrat from Texas, provided what I think is a very useful model, and I really do wish that Health and Human Services would look at this and follow this. He was trying to deal with inappropriate transfers of funds within the crop insurance program because he was on the Ag Committee. And I think a senior Democrat on the Ag Committee at the time. And it occurred to him, even within his own district, that there were crop insurance payouts that were far in excess of what would be expected in the area. So they developed a predictive modeling program with Dr. Burt Little at Tarleton State University in Texas, relatively small state university in Texas. And using this predictive modeling program, we're able to achieve significant savings in the crop insurance program. And what they found, much to their surprise, was once they started looking, the problem diminished. That is, people were willing to perhaps make embellished reports as long as no one paid any attention to them. But when there was seen that, in fact, there was this increased scrutiny, the numbers dropped. So I would just suggest that to you. I mean, we're all looking at ways to find additional dollars. And again, the gentleman's name is Dr. Burt Little down at Tarleton State. The crop insurance program that Mr. Stenholm developed through an earmark when he was in Congress turned out to be enormously helpful and protective of the program. Now look, we've had a lot of discussion here about a lot of different things. The Supreme Court is going to rule irrespective of the Republican budget. So forget for just a minute about any evil associated with the Republican budget. You have the Supreme Court going to rule. And you're telling me that you won't have the tools you need if the Supreme Court strikes down the entirety of the Affordable Care Act?
No, sir. There are important tools that are included in the Affordable Care Act, as well as resources for CMS and the Office of Inspector General. There are tools that precede the Act and resources that precede the Act as well.
Very well, and they will continue to be there and be utilized. And if you need additional authority because the Affordable Care Act has vaporized overnight, you will be able to come back to Congress and ask for that authority. Is that not correct?
The administration's focus is on using the tools that are current law to carry those out.
I get it. But there is a court case out there, and you admitted that you had read about it. Well, what you must be aware of in the law of the land is the Budget Control Act of last August. Dreadful piece of legislation. But nevertheless, it's there, and it proposes an 8% across the board. You're developing your budget, your fiscal year 14 budget now, are you not? You don't wait till the last minute to develop that.
That's correct. We're just now starting to enter into those.
Are you taking into account that 8% across the board hammer is hanging over your head January 1st?
We formulate our budgets each year under the guidance that comes from OMB. We typically would get that over the summer. What we're doing now is looking at, we're looking at our performance information, looking at priority areas, identifying where we can find additional savings, and the effort for the 2014 budget formulation will become more fulsome once we get the guidance from OMB.
Okay, well, Ms. Schakowsky correctly pointed out how the Pentagon is actively engaged in what it will have to do to deal with sequestration, and are there ways to avoid it? We don't hear much out of HHS, and you've got the same sort of Damocles hanging over your head as the Department of Defense. Let me just ask you this, going back to the Affordable Care Act, and I know you don't want to think about the Supreme Court, but you have a Medicaid payment rate. In fact, there was a story out today on Politico Pro about the Medicaid payment rate, which was just finalized. And it's paying Medicaid at the higher rate as authorized by Medicare. Are you prepared, if that goes away July 1st, are you prepared to step up to the plate and do something as far as provider payments in Medicaid? Or is that just tough luck for the docs?
For Medicaid, you mean with respect to the state federal share?
No, I'm talking about there was an enhanced payment rate in Medicaid up to the level in primary care, up to the level that is reimbursed by Medicare currently, so that there wasn't that discrepancy in the payment rates between Medicare and Medicaid. You guys going to take care of the docs if this thing goes away?
Well, the emphasis for CMS as well as for the department is to implement what is now current law and to carry out the provisions of the Affordable Care Act of Medicare and Medicaid.
You've told me that before. You know, your authority to pay providers under Medicare and Medicaid may evaporate July 1st, according to some AP reports that were out last week. You've got to be having some contingency plans on what do you do to keep the nation's doctors seeing your Medicare patients after July 1st in the absence of the Affordable Care Act. You just have to.
The emphasis of the department and of CMS is carrying out current law.
So this is the equivalent of taking the fifth on this issue. You're not going to tell me, but you have to be preparing. Because, I mean, again, I didn't make up this AP report. It bothered me when I saw it as well. I think we should be doing some contingency planning at the committee level. We, after all, are the committee of jurisdiction over these programs, but I cannot believe that your agency, that Secretary Sebelius and the administrator at CMS are not sitting down and at least looking at some black and white numbers of what do we do to take care of our docs if the Affordable Care Act vanishes in the morning dew.
Gentleman's time has expired.
But would the gentleman answer provide us a response? You've got to be doing some contingency planning.
The focus is on implementing what is current law, and CMS and the analysis that we are doing related to the Act has to do with...
Okay, Mr. Chairman, obviously I'm not going to get an answer, but what I would like to suggest is that this committee request respectfully from the agency information regarding this, because it is important. If every doctor doesn't get a paycheck July 1st, we're going to be in a hell of a shape. Perhaps we could request meeting notes, emails. There's bound to have been some discussions that have gone on at CMS about what happens the day after the Affordable Care Act is, if it is dropped by if the Supreme Court says it's unconstitutional.
Yeah, I think that the gentleman's correct. I think the committee can formally request from you what actions your agency intends to take in the event of deferral of budget money because of sequestration, the tools you're going to use. I think that's a reasonable request in the event this occurs. I think your agency should get back to us, as Dr. Burgess pointed out, with some chronology of things and tools you're going to do, because for you to continue to say we're just going to implement Obamacare, it's like he says, you're taking the fifth. And I think there is a point where Congress, oversight, our responsibility under the Constitution, we have a right to ask this and ask what you're going to do. And that's what I'm requesting formally, okay? Okay, we're going to wrap up this hearing. I have the opportunity to give some closing comments. You mentioned, Mr. Cochran, under Obamacare, that Obamacare provides additional funding to fight waste, fraud, and abuse in Medicare and Medicaid, I believe. But it's also true that there remains billions of dollars to be saved immediately only if Health and Human Service would simply implement all of the GAO's outstanding recommendations that were in Mr. Cosgrove's opening statement, that are in his written statement that he gave us. So I think before Health and Human Services goes around asking for more money, continue to have more money in order to cut waste, fraud, and abuse, we should start with the savings that the GAO has presented here clearly, abundantly, has pointed out, and obviously, in our opinion, and I think appears to be from the GAO, you have not implemented and responded to those recommendations, and you, in fact, pointed out one of them that you're going to totally disregard in dealing with the bonus program. So that is the closing comment, and I thank the witnesses for the hearing. We want to put, by unanimous consent, this little graph that we put on the slide on the television without objection.
Without objection.
So ordered. And in conclusion, I'd like to thank the witnesses and members that participated in today's hearing. I remind members that they have 10 business days to submit questions for the record, and I ask that the witnesses all agree to respond promptly to these questions. With that, the subcommittee is adjourned.
supplemental GAO recommendations, we don't need any words recommending.
Thank you, sir. Obviously,
Thank
this
you.
stuff's really important to me,
Yes,
so
sir,
I
I
appreciate you
understand that.
spending so much time with us this morning.
Well, I appreciate your
Thank you.
questions.
I almost left my budget here. Oh my God.
Oh, can't do that.